let's go ahead and get into eyes and ears. So eyes and ears. Nothing really too crazy with today's lecture. It's pretty basic. But we're going to go over some of the major eye and ear pathologies, things that you will very likely see in the future. Talking about like glaucoma, macular degeneration, things like even conjunctivitis. Those are all like really common types of conditions that you're going to see throughout your years in future clinical practice. So let's go ahead and get into some of the major diseases that we're going to cover. So we're going to talk about a few of those more common ear disorders, and then we're going to talk a little bit about your external eye disorders, like conjunctivitis being one of the most common ones. Hordeolum, that is, those are styes, so not as common, but still pretty common. Conjunctivitis is definitely pretty common. And then we're going to talk a little bit about different visual disorders, such as strabismus, cataracts. Cataracts, especially here in Arizona, very common because one of the main reasons is UV light exposure. So if you have a lot of UV light exposure, you're going to have a higher risk of developing cataracts. So that's something you're going to see a lot here in the Southwest. So let's watch a little video that talks about how hearing takes place. It's going to show you what you see in the external ear, the middle ear, and the inner ear. So let's go ahead and watch a little video that talks about all those different processes that takes place at every step of the way. All right, so that's kind of hearing in a nutshell. And so the different structures that you look at in the outer ear, you're going to see if you took an otoscope and you were able to listen or look inside someone's ear, you would be able to visualize the tympanic membrane, also known as the eardrum. Whenever the tympanic membrane vibrates, it's going to send signals to the malleus, incus, and then the stapes to conduct the vibrations into the cochlea. And so you have the vestibulocochlear system. In the cochlea, you're going to get vibrations causing sound production. The vestibular system has a bunch of semicircular canals that allow you to maintain your balance. Right? And we're going to talk about Meniere's disease in a little bit, where you would see issues and inflammation with like fluid accumulation within these different areas. That's going to cause vertigo. Right? So if your semicircular canals have any sort of issue, either due to like excess fluid accumulation, viral infections, things like that, you could potentially get vertigo as a consequence. So kind of the way that way you describe it would be like seeing the world spinning around, right? That's kind of what vertigo means. And then the eustachian tube is the part that connects down into the pharynx, right? So that would be the connection from your ears down to your oral cavity. So let's talk a little bit about hearing loss. So with hearing loss, Lots of people suffer from hearing loss. One of the major causes of hearing loss is just going to be age related. Right? So presbycusis would be your age-related type of hearing loss. And it's very common amongst a lot of older individuals. So about 50 million people experience some form of hearing loss. You guys know what tinnitus means? Some people pronounce it tinnitus. I pronounce it tinnitus. So tinnitus is going to be a ringing in your ear. So if you ever heard like a really loud sound and all of a sudden you start hearing your ear ringing, that's tinnitus. And some people have that like all the time. Some people experience constant tinnitus, which can be a consequence of just ear damage, or it could also be a consequence of certain medications or certain drugs that can also cause tinnitus. So imagine having your ears ringing all the time. 20% of Americans are going to be experiencing that at some point in their life. In terms of prevalence of hearing loss, it's going to be way more common than Parkinson's, epilepsy, Alzheimer's, and diabetes all combined. So lots of people experience some form of hearing loss. As I mentioned, it's going to be age-related, so the older you get, the more likelihood you are to lose your hearing. It's going to be more common in males versus females. Don't ask me why. Maybe it has to do with like the types of jobs that guys do. Maybe it's because guys like to listen to too much rock and roll music. I don't know. But guys are going to be experiencing hearing loss more than women. And devices that are being used by people. So like hearing aids. Lots of people are using hearing aids. And there's a lot of people also who have had cochlear devices or cochlear implants. And those cochlear devices are surgically placed so that you'd be able to restore an individual's hearing. So, when you're diagnosing hearing loss, there are two major physical exam tests that you could do with a patient. And I brought tuning forks so that we can actually do this to each other. So, I have 3 tuning forks. They're all going to be different frequencies. We have 128, which is in the key of C, low C. 256, which is a couple octaves higher, so it's a higher C. And then I have a 512, which is even higher than that. And they're all in the key of C. So can I get one person to be my patient? And then can I get 4 other volunteers to come up? So who wants to be my patient? You'll be my patient. Okay, you'll be my patient. And then let's get 4 more volunteers to come up. You guys got it? So we got 2. We need 2 more. We need 1 more. All right, good. We got 4 volunteers. Great. And so for you guys, I'm going to let you use the big one. You can use the big one and the less big one. I'm going to use the small one. The big ones I like a lot because it's really easy to get a nice sound produced from them. So what I usually use with these ones, you can do it a couple ways. You can either take the tuning fork and you can flick it, and then you'd be able to hear it. What I usually do, I just kind of slap it. Some people use their leg, and then you'll be able to like listen to the sound that the tuning fork makes. So you can do either of those techniques. That's either of them work. For the little tiny guy, I usually have to bang it on like a table or something like that, and then it works really nicely. You can't really do the flicking thing very well or the slapping thing. So there's 2 major tests. You got the Weber's test and you got the Renee's test. So with the Weber's test, we'll start with that one first. So that's going to be measuring localization, and you're going to be looking at either conductive or sensorineural hearing loss with that. On a regular, healthy individual that doesn't have any sort of hearing issues, you should be able to hear the sound equally in both ears. And so with the Weber's test, you can do it a couple different ways. When I was in med school, the way we learned it is you hit the tuning fork and you place it up to the person's glabella, which is going to be right here between their eyes, or eyebrows rather. And so you should be able to hear the sound conducting through your skull, right? Because your skull is going to act like a conductor to conduct the sound to your ears. And the little guy really sucks. It doesn't really work very well for the Renee's, the Weber's test. But if you guys want to try it on each other, so go ahead and bang the tuning fork, put it up to the glabella. I'll see if it works for you. Do you hear it in your ears? The small one's not that great, so I'll borrow one of the big ones from them. You don't hear anything? Maybe you have some severe hearing loss. There you go. So you could do that, or you could do the glabella. Some people, if they're, some people have really thick hair. You got nice thick hair, but you can still go to the top, the crown of the head, and you'd be able to hear the sound resonating through both ears. So try it again. Maybe you're just not hitting enough. Oh, the other thing you want to do, you want to hold it by the neck of the tuning fork. So you don't want to hold it here. If you hold it by the actual, like, the fork part of the tuning fork, then you're going to stop the sound. So try it again. See if that works. Still not? Did you guys get it? Yeah, did you? Now swap places and try it on her. So, yeah, this one sucks. Yeah. I'll swap with them after they're done. Yeah, I just actually, so the ones that I had from medical school, I only had like the smaller one that was still working. So I actually had to purchase new ones because the bigger one, it started to rattle a lot. So whenever I would do it, it would be like a big buzzing sound. So I got some new tuning forks just for today. I wanted to demonstrate this to you guys because it's fun. All right, so you should theoretically be able to hear it in both ears equally, right? Because it's going to be conducting through the skull. If you have one side being louder than the other, it could be either due to a conducting hearing loss or it could be due to a sensorineural hearing loss. And then so the other test that you could do is a Rene test. So let me actually get this big guy from you so I can show it. Better? Do you hear on both sides equally? Yeah. Okay, good. So you have no conducting hearing loss, which is great. The other test that you could do is kind of similar. So this is the Rene test. So you hit the tuning fork, and then you place it on the mastoid process. And that's going to be the bony prominence right behind your ear, right? And so you hit the tuning fork, put it on their mastoid process, and they're going to hear the conduction of the sound of the tuning fork. As soon as they stop hearing that, you have them like raise their hand, and then you switch over, and then you place the fork near their ear. Because air conduction should be greater than bone conduction. So you should be able to hear it even after you stop hearing it on the bony prominence. So here, let me get Kira to demonstrate for me. So, all right, cool. So let me know whenever you stop hearing the sound, just raise your hand, okay? Hear the vibration? All right, good. So if you weren't able to hear the sound, the air conduction, then that could be due to some sort of abnormality going on. So if you had, for example, bone conduction was louder than air conduction, you might have some sort of conductive hearing loss. Okay, so do you guys want to try it on each other? So hit the tuning fork. So you hit the tuning fork, put it against the mastoid process, and then have them raise their hand when they stop hearing it. The moment they stop hearing it, then they switch it over. Is it too much? No, I don't hear it. Really? So, how are you doing it? It should be working. I hear it. So it takes practice when you're learning how to use your tuning forks. So were you able to hear air conduction? So yeah, air conduction is supposed to be greater than bone conduction. So I'm going to leave these up here for you guys. If you guys want to tinker away with them after lecture, you can feel free to do so. Yeah? They sound really cool. Tuning forks sound really neat. And my colleague, Dr. Jackson, was asking, have you ever used a tuning fork to tune any of your instruments? I actually never have. So I have tuners for all that. I have like a guitar pedal tuner, and I use a tuner for my iPhone for like acoustic instruments and stuff like that. But tuning forks, you could theoretically tune an instrument to a tuning fork. But it's nice to use these for different types of hearing loss tests. So Weber's test, middle of the head, you should hear it equally on both sides. Rene's test, mastoid process. When you stop hearing it, then you put it up to the ear, and they should be able to hear air conduction greater than bone conduction. And here's another depiction of what that looks like. So here's your Weber's test. It should be equal on both sides. And if you have abnormalities, it could be conductive versus sensorineural loss. All right, so moving on. Speaking of sensorineural loss, that is going to be the most common form of hearing loss. So 90% of all hearing loss is going to be sensorineural. It could be due to issues with the cochlea, or it could also due to the vestibulocochlear nerve, which is cranial nerve number 8. It's going to be a slowly developing type of hearing loss. And the symptoms, the individuals are going to have a difficult time hearing voices with a lot of background noise. Right? So if you're in a public place and there's a lot of background chatter or something like that, and you try to talk to the person, right? And if they can't understand what you're saying, that could be sensorineural hearing loss. Women's voices, because a woman's voice is going to be, on average, a little bit higher in frequency than men's voice. You tend to start losing higher frequencies first. Lower frequencies you lose much later on, but you start losing your higher frequencies first. So you're going to have a hard time hearing women. You might have a hard time hearing children. You might have a hard time hearing other high-pitched sounds like birds, ticking of clocks, things like that. Presbycusis, Meniere's disease. These are the major causes. What is presbycusis? So that's age-related hearing loss. So presbycusis means that the person is just old and they just lost a bit of their hearing. So that's normal age-related hearing. Meniere's disease is going to be a little bit different. That's going to involve inflammation and fluid accumulation. And we'll talk about that in a second. But if you had any exposure to loud noises, like veterans, for example, if they're like surrounded by artillery fire or even like, shooting guns, over time, that's going to cause some severe damage to the ears. Rubella could cause that. Low birth weight. Whenever a person has low birth weight, they might experience hearing loss as they get older. And then certain medications can cause this, right? So remember I talked to you about like tinnitus? So there's certain meds that have a higher rate of developing tinnitus in the patient. So gentamicin, streptomycin, quinine drugs, cisplatin, aspirins. So those are going to be drugs that can potentially cause hearing loss. The other type, besides sensorineural hearing loss, is going to be conductive hearing loss. And this is going to be the second most common type. And that's only going to be 10%. So you're having a difficult time getting the sound to transfer from the outer ear into the inner ear. And so very similar things as sensorineural hearing loss. You're going to have difficulty hearing speech. Voices are going to sound a little different. But for this, it might be easier to hear out of one ear than the other. Okay? Because sometimes it can just affect one ear, so it might be unilateral. There might be pain associated with it, and you might experience pressure. It depends on what exactly it is that you're dealing with. Otitis media is going to be a cause of this. Otitis media is a middle ear infection. So if a person says, oh, I have an ear infection, they're usually referring to otitis media. And that can happen at any point in your life, but it most commonly affects children. And when it affects children, the most common type is going to be due to, oh my gosh, I just had a brain fart. Haemophilus influenza. Oh my God, I can't believe I forgot that. So Haemophilus influenza for children is going to be the most common cause of otitis media. And the big concern with that one in particular is that Haemophilus influenza can also cause meningitis. And so if you have like a young kid, usually under 5 years old, and they develop a middle ear infection, you definitely want to treat that patient with antibiotics, because think about how close your ears are to your meninges. Right? It's very close. The bacteria can easily make its way down into your meninges, causing meningitis. And then autosclerosis is going to be another common cause of conductive hearing loss. And autosclerosis is going to mostly affect the stapes. It can affect the other bones too, but the most common one is going to be the stapes. And what autosclerosis is, it's going to be excessive amounts of bony growth that's going to affect the bones of the inner ear. Other things that can cause conductive hearing loss: cerumen or earwax. This happened to my dad like a year and a half ago. He had a really hard time hearing, and it's because he had a lot of earwax. And as soon as he went to the doc, got the earwax removed, voila, his hearing came back to normal. So that can happen too. If you have any sort of allergic reaction or a cold, that can affect your ears as well. If you perforate your eardrum or have foreign objects in there, that can also cause damage, or no, not damage, but conductive hearing loss. And here's a fun video I saw. I saw this on Medical Talks the other day, and even though it doesn't involve hearing loss, I thought I would share it with you guys because it's really wild. So that's inside someone's ear, and that is a spider. That is a baby jumping spider. And you can see the little exoskeleton right there. So it actually molted in the person's ear. So if you go into Medical Talks and you read about that patient's history, so it's like an older lady, and she was like hearing this kind of like scratching, biting, ruffling noise within her ear, and it was actually keeping her awake at night. And she was feeling a little bit of discomfort, and that's when she went to go see the doctor, and they found that on the otoscope. If you look up online, you can actually find other really interesting videos of spiders getting stuck in people's ears. There's this one that was a pretty small spider. There's another one where it's like a really like large jumping spider that was trapped in the person's ear. They were able to extract it using like a little vacuum cannula, but if it's really big, because you don't want the whatever bug or organism like freaking out and then causing damage. Usually you want to inject a little bit of ethanol in there to like kill the organism, and then you like can suction everything back out again. So what was your question? I'm sorry, I didn't catch that. Oh, because of the cold? Yeah, yeah. Like you feel kind of like burning, right? That's just from the cold, just cold exposure. Yeah, that's not really affecting like the eardrum itself, but that's just like pain and irritation to just the external ear, right? So that's basically it. When you're outside and it's cold out, why do you get something that affects your actual eardrum when you're exposed to the cold? Yeah, I mean that's like your fingers are gonna hurt. Oh, cold, like getting like a head cold, not actual like cold temperature. But like if you had a upper respiratory tract infection, like rhinovirus, any of those, like coronavirus, anything that causes a head cold. Yeah, I should have clarified that on there. So yeah, not cold weather, but an actual like viral infection, then that would cause like inflammation and irritation, and you could potentially get fluid accumulation in different parts of your ear. Yeah, but cold weather, that's just gonna like the cold itself is gonna actually cause the pain, not the viral infection. But good question. I'm going to try to update that slide so it reflects that it's a URI, not just cold weather. But that's pretty wild with the spider video, right? Kind of spooky. Otitis media. So this is where you have a middle ear infection. And it is going to be most common in young children. So usually up to about 5 years old, you'll get otitis media. Has anybody in here had otitis media ear infection? Yeah? Was it bad? What happened? When you were young? Oh, yeah, that can definitely happen. Did you ever have to get tubes? Tympanostomy? You did, really? Oh, wow. Anyone else in here ever had a tympanostomy too? Oh, that sucks. And the change in pressure. Oh, that sounds horrible. How young? How old were you? Oh my God. And you never forgot that, huh? I had otitis media, and I had like vivid, insane hallucinations. I had a really high fever, and I was very sick when I had otitis media, and it's so uncomfortable, very, very uncomfortable. And I don't think I took antibiotics for it, which is dangerous. Like you really want to get treated for it because it can cause some serious damage, especially if it turns into meningitis. So when you do your otoscope and you look into the person's ear, you're going to see erythema, which is redness, and then you're also going to see bulging of the TM is your tympanic membrane. So the tympanic membrane is going to be completely bulged out because of that. So this is what a normal ear looks like. You can see, you can see the malleus, the incus. You can't really see the stapes in this image, but that's a nice, clear-looking tympanic membrane. This is a wildly inflamed tympanic membrane due to otitis media. You can't see any of the bones. All you're basically seeing is purulence, pus behind the tympanic membrane. You want to treat this with antibiotics. And if it's reoccurring, you can do a tympanostomy tube. So let's watch a little video on that.
I'm a mother of a 1-year-old daughter who has had at least 6 ear infections in the last 6 months, which makes her actually one of the potential candidates for ear tubes.
I took this clinical otolaryngology class at Mass Eye and Ear last year, where we actually looked inside each other's ears. And when people would look in my ear, they could see scar tissue from actually when I had ear tubes when I was 2 years old.
Tympanostomy tubes, also known as ear tubes, are devices that are placed frequently in children, but also in adults, under conditions of recurrent ear infections. And that is to evacuate fluid that is stuck behind the eardrum or to ventilate the ear in order to infections take place. Current ear tubes, as we know them, are very much unchanged from when they were first introduced about 40 years ago and have had persistent problems.
Sometimes the ear tubes get clogged, and administration of topical antibiotics do not make it into the middle ear. They can be prematurely extruded, they can be very invasive and cause perforation, scarring tissues, and potential hearing loss. Sometimes they have to be reinserted, which leads to more surgeries under general anesthesia, which are truly undesirable by patients and parents.
I think that some advances within material science that have occurred over the last few years may be able to address these issues.
But move types in our bodies, and they are supposed to be friction-free. So nature has evolved already how to make piping non-adhesive to bacteria, non-adhesive to a range of other biological solvents.
Our team leverages unique biocompatible materials and science, and we utilize easy to manufacture rather silicon injection molding.
Not only that, it makes the tube non-adhesive to microbes, but it actually creates unique transport properties. In one direction, the tube is capable of releasing tension and otitis media coming off the inflamed area, and in the other direction, to have antibiotics, drugs that can be delivered to middle ear to treat the infections. That is highly unique, customizable feature that has never been seen before.
So this can reduce otorrhea. This can also prevent premature extrusion of the tube in patients, so there's more predictable time frame.
In vitro results are incredibly promising. We look forward to animal studies through an animal model that's already established. We hope to be able to consider a human clinical trial in the not too distant future thereafter.
That's some cool research in the world of tympanostomies. Now, with a younger individual, like if you guys are going to be working with pediatric patients in the future, one of the hallmark signs that a child is having otitis media is, they can't talk to you, right? They're young toddlers. They're going to be tugging at their ear, right? And so that's going to be a huge giveaway that a young kid is experiencing otitis media if they can't vocalize that to you. You're also going to see irritability and crying, but pulling and tugging at the ear is going to be a huge sign that the kid has otitis media. All right, so let's talk about otosclerosis for a little bit. Otosclerosis is going to be abnormal bone growth, and it's going to be mostly due to genetic issues. It is going to be bilateral, and it's a slow progressive type of loss of hearing. And because it's affecting the stapes for the most part and the bones of the middle ear, it's going to be considered a conductive type of hearing loss. So it's not sensorineural. This is a conductive type hearing loss. You could do surgeries. You could obviously try to give the person hearing aids, but hearing implants would also be a consideration for those types of patients. Then there's presbycusis. Presbycusis, this is your age-related hearing loss. So the older you get, the more likely you are to lose hearing over time. And again, it's going to be bilateral, right? So that means you're going to have it affecting both ears. This is the most common form of hearing loss. Right? As people get older, right, they're going to eventually start losing some of their hearing. And you get a progressive decrease in the hearing thresholds, as well as a difficult time understanding speech. Again, hearing aids would be one treatment option, or if it's severe enough, you could also consider a cochlear implant.
We've gathered a group of volunteers ranging in ages from 8 to 71, putting them to the test in our first Battle of the Ages contest. All right, you guys, I'm going to play a series of sounds. If you can hear the sound, I want you all to raise your hands up. Your right hand, you can keep it there, all right? For those of you watching at home, feel free to play along. Ready? 8,000 hertz. All right. All of you can hear that first frequency. I'm going to play another sound, another frequency. You still hear it, keep your hands up. If you can't, bring your hand down. 10,000 hertz. Okay, we seem to have lost our 60 and over crowd. You guys look great, though. Let's raise the frequency even more. 14,000 hertz. Okay, we lost you. Bit, I can tell. 16,000 hertz. Okay, at 16,000 hertz, we've lost all of our grown-ups. But we still have our youngest members of the crowd with their hands up. Luke, tell everybody how old you are. 8 years old. Fresh ears. Still can pick up these faint frequencies. Nice work. Now we're taking it up to 18,000 hertz. You guys ready? 18,000 hertz, we've lost 23 and 19. But the under 18 crowd is intact. 18,000 hertz. That's pretty impressive. Enjoy it while it lasts. So, how about you at home? Were you able to pick up that final tone? Or were you left listening to the sound of silence? Well, either way, you may have noticed a trend. As this chart shows, the higher the frequency, the younger you typically have to be to hear that sound. So why is that the case? What does it have to do with your brain? To help answer that, here's Yale University's Brian Scholl.
Sounds out in the world are just vibrations in the air. But what we hear is determined by patterns of neurons firing in our brains. So the first step in hearing a sound is to somehow translate an air vibration into an electrical neural signal. This is done by microscopic hair cells in our ears. Different hair cells are activated by different frequencies of vibrations. But as we age, these hair cells start to deteriorate, so that we gradually lose the ability to hear these frequencies.
What? Who knows? Your kids could be using a high-frequency ringtone. That would be even no. So the first point in our Battle of the Ages goes to the younger brain. This next game is going to come down to experience. So older brains should have the advantage.
Watch that on your own time. Where did you all get cut off at? I got cut off at about 14,000 hertz. 19? 16? All right. Stop rubbing it in my face. Well, I'm in my late 30s now, so yeah, I'm well on my way to getting presbycusis. All right, Meniere's disease. This has to do with fluid accumulation. So you're going to have fluid accumulation within the inner ear, and that's going to cause Meniere's disease. Generally speaking, this is going to happen to individuals between 40 to 60 years of age, and there's the triad of Meniere's disease: tinnitus, vertigo, and hearing loss. Those are the 3 things that happen with Meniere's disease. Let's watch a little video on vertigo.
Finally, the room goes like a spiral into space. You know, you feel like you're flying off the bed. I knew immediately what it was because that's my job. So we have the cochlea, the hearing part of the ear, and then we have the semicircular canals, the spinning sensors. So what happens is the particles that are in the neutrophil can sometimes get into this opening. When you lie down in bed at night, particles can just fall in by gravity. And then when you sit up in the morning, they get all the way down here to the bottom of the ear. But when the particles build up to a big enough clump that they form a piston in the canal, then when you move your head like this, the particles move a sensor in the structure, and you feel that spinning. And I knew that the particles were here from in this room. And so I had to figure out how to get them out. So I made a little model with my hands like this, twisted and turned it, figuring out a new way to do it. And I realized if I would forward, I could get the particles out. I made up the half somersault, did it, came up, and it was gone. You start on your knees and you tip your head straight up to look at the ceiling, and you hold that position for a few seconds. You'll usually feel a little bit of a spinning. That helps start the particles moving. Then you put your head completely upside down, tucking your chin a little bit so your head isn't perfectly vertical. It's actually tucked slightly towards you. So during that time, you turn your head towards your right elbow if you're going to treat the right. If you're treating the left ear, you turn the head to face your left elbow. The side that you get the most dizzy when you're lying down and rolling over. So if you roll over to your right, and that makes the spin, and you roll to your left and it goes away or it's not as bad, then you have it in your right ear. In that position, the particles will start to move, and you will feel the spinning. You wait for all the spinning to stop, or you can count to 30. And then very quickly raise your head to back level. So your head and your back are on the same level. But you're keeping your head turned at that 45-degree angle. Then you again wait for the spinning to stop, 15 to 30 seconds. And then you bring your head fully upright so that you end up kneeling. And in that position, the particles should be here. Sometimes it takes 4 or 5 repetitions. The safest thing is to repeat it with 15-minute breaks between each. Because that allows the particles to fully settle out away from the opening. If you can't get rid of it, even after time, you can always see a doctor and go in and out.
So this is for benign paroxysmal positional vertigo. So that's a different condition, but it illustrates like how vertigo kind of feels like. You get that sensation of the room spinning, the structures that are actually affected. So that's going to be your semicircular canals. And if you had benign paroxysmal positional vertigo, there's different maneuvers that you can do, like she was demonstrating in that video. So different maneuvers that you can get, otoliths and things like that to move out of place so that you can actually get proper flow of fluids through there. But with Meniere's disease, the accumulation of the fluid and all of that pressure is going to affect those semicircular canals, and that's how you get vertigo as well. So this would be considered a sensorineural hearing loss. And you will feel pressure and fullness in the ears. Generally speaking, it's going to be unilateral. Vertigo can last a while. And if you're feeling like the world is spinning around you, you can get very sick, right? So this can cause nausea and vomiting. Anybody in here get vertigo? Really? Do you get nauseous? Wow. Is it that? Is it benign paroxysmal positional vertigo? Oh, weird. Oh, interesting. Someone else said you get vertigo too? Is it pretty bad too? Do you get like nausea and vomiting? Oh, wow. So the med was causing the side effect. Do you remember what medication it was? If you're willing to disclose. If not, that's fine. Oh, and it caused vertigo. Interesting. What's up? Oh, and you get seasick? For the rest of the day, you're just feeling nauseous. Yeah. Uh-huh. It's like, it's not, if you're not feeling sick and like when you go on a cruise ship and when you get on land, you're like, whoa, what's going on here? Like everything feels like it's moving. It's like your brain, it's been kind of like being on the water has been training your brain to maintain posture, right? And kind of like move along with the waves and the currents of the ocean. So that would involve the semicircular canals. So there would be involvement in that. But with seasickness, that's also like involving the semicircular canals too, and then just getting violently ill as a consequence of the motion, right? Which you can treat. You can take drugs like Dramamine. A buddy of mine, one of my best friends from med school, he would get violently ill even on car rides. And the island that we went to med school at, there was like there was only 2-lane roads, and they would cut through the mountains and like forests, and they were and like the drivers were like all crazy. And so like if you're in the car, if you got seasick, you would get motion sickness in the vehicles too. So he would always like pop a bunch of Dramamines, fall asleep, because Dramamine makes you really, really tired and sluggish. But yeah, that's a really good question. Yeah. Has anybody experienced that when they got off of a boat? Like you feel kind of like the world is kind of, yeah, it's kind of interesting. Super cool. All right, so with Meniere's disease, treatment, you want to tell the person to avoid certain things like caffeine, alcohol, nicotine, and sodium, right? Sodium is pretty obvious because if it's involving fluid accumulation, water follows solutes, right? So that would help to minimize the amount of fluid accumulated in the ear. But then I'm not really sure exactly the mechanism behind the caffeine, alcohol, and nicotine, but telling patients to abstain from those tends to help individuals with Meniere's disease. All right, now let's shift from ears and let's start talking about eyes. So let's talk about some of the structures on the external eye. So you're going to have tarsal glands, which are also referred to as meibomian glands, and those are going to secrete oily substance, and that's going to be sebaceous. Those are sebaceous glands. And sebum is going to be an oily type lubricating substance. If you get an infection of the tarsal glands, that's going to turn into a stye, also referred to as a hordeolum. So hordeolum is another term for a stye, and that's going to be due to a bacterial infection. You get a little bit of a painful inflammation of the area that's affected. You get maybe some tearing. You get swelling, and the treatment for that, warm compress. That's basically it. You're not really going to be doing much else with that. Here's something I'm not going to be testing you on, but it's also kind of good to be familiar with: keratitis. And so one of the most painful parts of the eye is going to be around the cornea, right? So if you poked your cornea, that doesn't feel good. If you were to touch the sclera or the conjunctiva, no big deal, right? But you have a lot of pain receptors on the cornea. And if you have inflammation or an infection of the cornea, we refer to that as keratitis. And it can be due to a lot of different types of organisms. It could be viral, bacterial, it could be fungal, it could be a parasitic type infection. And this is a medical emergency. That person is going to go blind if they don't get immediate treatment for that. And so they want to definitely go to see their ophthalmologist right away. And then you can culture it, of course, and depending on what the underlying organism or parasite or pathogen is, then you would treat it accordingly, right? So if it's bacterial, antibiotics; fungal, antifungals, etc. Conjunctivitis is going to be on the exam. So with conjunctivitis, there's different types of conjunctivitis. There's going to be bacterial conjunctivitis, viral, as well as allergic conjunctivitis. And this is what we commonly refer to as pink eye, right? So if somebody has quote-unquote pink eye, that's going to be conjunctivitis. And depending on what type of conjunctivitis the person has, it can be extremely contagious. And so what's going on with conjunctivitis? The whites of your eyes are your sclera. The components beyond the eyes that are adjacent to the eyelids, that's going to be your conjunctiva. And so with conjunctivitis, you're seeing involvement of the conjunctiva as well as the sclera. The sclera is going to be inflamed as a consequence. If it's non-infectious, that's going to be allergic. If it's bacterial versus viral, those are the ones that are going to be infectious, right? Very contagious, especially viral. Viral conjunctivitis is highly contagious. And for viral conjunctivitis, it's usually going to be, there's going to be a head cold before you get the viral conjunctivitis, usually. So it can be preceded by a upper respiratory type infection. And then the treatment is really just going to depend on what it is, right? So if it's like a bacterial conjunctivitis, you give the person antibiotics, gentamicin, things like that, erythromycin. If it's viral, you treat it for like the viral infection, right? So you could give different types of meds depending on what it is. If it's allergic conjunctivitis, you can just give the person antihistamines, right? Antihistamines should be able to address any sort of allergic conjunctivitis. I used to get this a lot when I was younger from cats. One of my best friends when I was growing up, he had lots of cats, and every time I would stay at his house, I would get really, really irritated eyes as a consequence. People get this during hay fever season, right? So if you're getting during the spring, especially if you're sensitive to pollen, things like that, you're gonna see more people getting allergic conjunctivitis. Now, the difference between allergic and viral conjunctivitis compared to bacterial conjunctivitis is purulence. So with a bacterial conjunctivitis, you're going to see a lot of purulence as a consequence. And with that, lots of pus, right? And if they wake up in the morning, it's going to feel like their eyes are glued shut, right? Because you have like so much pus just forming around the eyelids. That makes it really difficult to open up. If you have any sort of infection of the tear ducts, that's called dacryocystitis. I'm not going to test you on that one, but just know the difference between bacterial versus viral versus allergic conjunctivitis. Now, signs and symptoms, of course, you're going to have redness, swelling, tears. If it's bacterial, you're going to have lots of discharge. It's going to be purulent. It's going to cause crusting type lesions. And viral, it's going to be watery discharge with some itching. Now, bacterial and viral are usually going to be unilateral, but that's not always the case. Like my ex-girlfriend had a really bad case of viral conjunctivitis. It affected both of her eyes. She looked like a demon. Turned out later that she was a demon, but she had a really bad viral conjunctivitis, and she got it from her work. One of her colleagues was like using the computer where she worked at, and he had some issues. They had like some sort of like upper respiratory tract infection. She was using the same computer, and a few days later, she came down with bilateral viral conjunctivitis. So pretty wild. It was really, really intense. I've never really seen anything quite like it. Versus allergic conjunctivitis, it is usually going to be bilateral. Almost always bilateral, right? Because allergic reactions are going to be systemic. And so it's going to affect both of the eyes. Versus bacterial and viral, it's sometimes going to be unilateral, sometimes bilateral. How long does it last? It lasts a really long time. Like, back to my ex, she had it for about 2.5 weeks. So a really long time. How do you prevent infectious forms of conjunctivitis? First of all, don't touch your eyes, but also wash your hands, right? Because it's very easy to get. So wash your hands, prevent the spread of that stuff. So nasty, not fun. Cataracts. As I mentioned earlier, cataracts are going to be pretty common in areas like the Southwest, right? Where you have lots of sun exposure, lots of ultraviolet light. And also, depending on what part of Phoenix you're in, some areas are going to be older than others. So aging is going to be another risk factor for getting cataracts. I grew up in a pretty old town. It's like a retirement town, so I knew a lot of people that had cataracts, a lot of people who had cataract surgery, which I'm going to show you a couple of videos here. But what's going on with cataracts? You're getting a clouding and opaque discoloration of the lens. And with UV light, you're getting free radical damage, right? So the UV light is going to be causing all sorts of issues with the cataracts. And it's slow. It takes a long time for people to develop cataracts. So it's a long ongoing process. But then once it gets serious enough, then you start getting cloudiness, blurry vision. You're going to have a difficult time perceiving colors. You're going to have a difficult time with night vision. So let's watch a couple of videos.
A cataract is a clouding of the lens in your eye that affects vision. Most cataracts are related to aging. To understand how a cataract can affect your vision, it helps to understand a little about the structure of your eye. The lens is clear and lies behind the iris and the pupil. It works much like a camera lens, focusing light or an image on the retina. The retina is the light-sensitive tissue at the back of the eye. Once the light or image reaches the retina, it is changed into nerve signals that are sent to the brain. Besides focusing light on the retina, the lens also adjusts the eye's focus, letting us see things clearly both up close and far away. The lens must be clear for the retina to receive a sharp image. The lens is made of mostly water and protein. The protein is arranged in a precise way that allows light to pass through it without distortion. But as we age, the proteins in the lens clump together, causing a cataract. At first, the protein may clump together and cloud a small area of the lens. Over time, the clouds may increase in size and number, clouding more of the lens. If the lens is cloudy from a cataract, the image you see will be blurred and colors may appear faded.
All right, now let's watch some videos on what cataract surgeries involve. So here's an animation of a cataract surgery, and I'm going to show you an actual video of one.
In the first step, the surgeon uses a blade to make incisions in the cornea, the outermost layer of the eye. This allows the surgeon to access the inside of the eye to remove your cataract. The placement and size of these incisions can affect the visual outcome, so it is important that these incisions are made with accuracy and precision. The next step in cataract surgery is called capsulorhexis. During manual cataract surgery, the surgeon uses a handheld instrument to cut and gently create a circular opening in the sac that holds the lens, called the capsular bag or lens capsule. This provides the surgeon with access to the cataract. Capsulorhexis is a critical step in cataract surgery because it can affect how an implanted IOL will be positioned in the capsule. If the capsulorhexis is not done with a high level of accuracy, the position of the lens may not be ideal, which may lead to a less than optimal vision outcome. After capsulorhexis, the next step in cataract surgery is phacoemulsification, or phaco. During manual cataract surgery using phaco, the cataract is manually broken up into many small pieces in preparation for its removal. An instrument called a chopper may be used first to break up the lens into a few large pieces. Then the phaco instrument is used to break up the lens using ultrasonic energy. Once the lens has been broken up or fragmented, it is removed using suction and an IOL is placed into the capsule. The amount of ultrasonic energy can affect the recovery process and visual outcome because too much ultrasonic energy released during this step may cause damage to the cells and tissues inside the eye. In LENSAR laser-assisted cataract surgery, the blades used in manual surgery are replaced with a precise and accurate laser, which also helps to minimize or eliminate the need for ultrasonic energy to break up the lens. In a LENSAR laser-assisted cataract procedure, the capsulorhexis is created first. Guided by LENSAR's detailed image, the surgeon accurately places the laser spots in a circular pattern to create the opening in the capsule. Because the LENSAR laser allows for such accuracy during capsulorhexis, positioning of the new lens can be optimized, which may lead to an improved vision outcome. The next step in the LENSAR laser-assisted cataract procedure is to fragment the cataract into small pieces. LENSAR does this very efficiently, which reduces the amount of time and ultrasonic energy needed to further break up the cataract before it can be removed. In some cases, LENSAR has entirely eliminated the need for ultrasound energy. This reduction in ultrasonic energy released into the eye may reduce the risk of certain complications and may potentially speed up healing time. The last step of the LENSAR laser-assisted cataract procedure is the creation of corneal incisions. The surgeon is guided during this step by another unique imaging feature of the LENSAR laser called intelligent incisions. Intelligent incisions allows for the incisions to be made with accuracy and precision and can contribute to the quality of the vision outcome. Following the LENSAR laser-assisted cataract surgery, the cataract is removed and the IOL is placed inside the capsule. Because LENSAR fragments the cataract so efficiently, a LENSAR laser cataract procedure may reduce the amount of time it takes to remove the cataract during this step. By choosing LENSAR laser-assisted cataract surgery, you are choosing the most advanced cataract procedure possible
Okay, sales pitch. Let's watch an actual video.
Main wound incision. This is followed by a capsular rexus technique, during which I make between 5 and 5.5 millimeters capsular rexus. Great care is taken to make sure it's complete. After capsular rexus, hydrodissection is used to free the nucleus within the capsular valve. Viscoelastic is injected, and then a stop and chop phacoemulsification procedure. I phaco down the center, and I crack the nucleus. I turn the nucleus a few times, get purchased on one half of the cataract. This half is then chopped by the phacoemulsification and the dry zero secondaries. Second piece is brought up at this point. After phacoemulsification, irrigation and aspiration are used to remove the cortex from 360 degrees, make the visual axis clear. Viscoelastic is then injected after the cortex is removed. Once the viscoelastic is injected at this point, the lens is inserted, slightly decentered, so that I can then go behind the new lens, remove the remaining viscoelastic here. Those bubbles will come out. At this point, the lens is centered, the wound will be secured using down salt solution. Antibiotics will be injected. Petrocaine will help to create a hypoosmotic effect and close the wound. I check the wound, and we're done.
Pretty cool, huh? Super cool. And by the way, those are done under local anesthesia for the most part. The patient is still awake. And not just local anesthesia, but they're also giving a anxiolytic type of medication. And the anxiolytics will help to calm the person down so they don't feel like anxiety while they're getting the doctor poking into their eyeballs. So yeah, pretty interesting procedure. Also kind of unsettling, right? Anything that involves the eyes kind of freaks me out too. So any question on cataracts? All right, let's talk about glaucoma now. So glaucoma. There are two major types of glaucoma. There's going to be open angle glaucoma and there's going to be closed angle glaucoma. One is worse than the other. The most common one is going to be your open angle glaucoma. This one is painless and it's gradual. So it happens over a long period of time and the person doesn't even know it. Here are some of the risk factors. So diabetes is a risk factor, hypertension, being old. African Americans have a higher rate of this. And if you have a family history that predisposes you to getting open angle glaucoma. If you were to look at the person's retina through an ophthalmoscope, then at the optic nerve here, you're going to see all that pressure over time is going to cause excess cupping of the optic nerve. So this is what it would look like as well if you're looking at it just directly on, right, through a ophthalmoscope type exam. So here's your healthy eye, and there is your optic nerve cupping. Now, closed angle glaucoma, oh yeah, by the way, even though open angle glaucoma is not as severe, it's still going to eventually cause blindness in the patient. So it can still cause severe damage over time. But it's painless, the person doesn't notice it yet. It's only really seen if you have elevated intraocular pressure. Have you guys ever done your eye exams before? So anyone who wears glasses in here or contacts, they'll blow a little spurt of air, right? It's kind of like uncomfortable. But that little spurt of air, they're able to test to see what the intraocular pressure looks like. So if you can test intraocular pressure, if you have elevated intraocular pressure, that is consistent with glaucoma. Over time, that's going to cause damage to the retina. Now, closed angle glaucoma is really painful, and this is a medical emergency. The person needs to go get medical attention right away. they're going to get a sudden change in vision, so it might become very blurry. They might start seeing halos. Their pupil might be fixed and dilated. This could be a medication side effect. But let's watch a little video.
If you were diagnosed with narrow-angle glaucoma, your doctor may perform a procedure called laser iridotomy to decrease the risk of a sudden and dangerous buildup of pressure in your eye. Before the procedure, your doctor will place drops in your eye to constrict the pupil. Then, using a precisely focused beam of laser light, your doctor will create a tiny hole in your iris. This hole acts as an alternate channel through which fluid inside the eye can flow if the usual pathway becomes blocked. The hole will not affect your vision, and in most cases is positioned under your upper eyelid so that no one will be able to see it. Soon after the procedure is completed, you may return to your normal activities. Though a laser iridotomy is sometimes performed to relieve a sudden buildup of pressure in your eye that is already underway, it is much more commonly recommended as a preventive measure before there are any symptoms at all.
All right, now let's watch another video here. Oh, it's the same one. Okay, never mind. All right, and then open versus closed angle. What does it mean by open versus closed angle? So with an open angle glaucoma, that's where the drainage is, it's not being siphoned off by the closing of that space where you would have drainage into the drainage opening. It's just that the drainage is getting clogged, right? So you're preventing drainage of fluid or the vitreous humor out of the inside of the eye. Closed angle glaucoma is a little bit different. So you're like narrowing down that angle, and now you're basically blocking out that drainage. And this happens suddenly when you have a closed angle glaucoma. So it's a little bit different. All right, amblyopia. Amblyopia is your lazy eye. It could affect one of the eyes, or it could affect both of your eyes, and you're going to have a hard time seeing clearly. Now, the way that you can describe this is there's kind of a mismatch between the brain, what the brain is trying to do with your eyes, and what your eyes are doing. So there's a communication mismatch between your brain and your eyes. There's a bunch of different types of amblyopia, but the most common is going to be strabismus. You're going to also see this in pediatric patients, and you want to correct this right away. So you want to do make sure you diagnose it early. You want to treat this early. Otherwise, if you don't treat it, the patient will lose the vision in the affected eye. Okay, so that's one of the major things that's going on. The reason why that happens is because the portion of the brain that's processing visual information is effectively going to kind of atrophy, right? It's kind of like a use it or lose it. And if the affected eye is not really seeing properly, to be able to correct for that, your brain is going to focus on the unaffected eye for the most part. And so you're going to eventually lose vision completely. And that is irreversible. It's permanent vision loss. And so you want to treat these patients within a matter of like a year or two. After 2 years, however, treatments are not going to be very effective. And so what do? You give the patient an eye patch, occlusion therapy. Or you could also give them different types of corrective lenses. And there's also vivid vision therapy too. So let's watch a little video on that. Okay. So strabismus, as I mentioned, that's going to be the most common form of amblyopia, and that's where you're having misalignment of the eyes. This could happen to one, or it could happen to both of the eyes. This can happen when you're born, or it could happen later on in your life. It could be due to family history, genetics. If you have a stroke, of course, that can affect some of the extraocular muscles. Head injury, of course, that's going to affect the nerves that innervate the extraocular muscles. So what you're getting is misalignment, double vision, or diplopia. And your brain will try to correct for this over time. So it is going to shut off the eye that's affected. And that's why if you don't treat this earlier on, this is irreversible. Right? The brain will shut that part of the brain, the region of the brain off that is processing vision from the affected eye. A person that has strabismus might have to tilt their head to be able to see properly. They might also get headaches, diplopia, double vision. They're probably going to complain of strain. They're going to have difficulty doing all sorts of things that involves vision, right? So there's many different types of strabismus. I'm not going to test you on all the subtypes of strabismus. Just know like the general concept. Yes? Oh, really? Did you have to get it treated? Wow. You have another surgery coming up. Wow. That's interesting. Have you had any? You haven't had any vision loss or anything like that, right? That sucks. Have you had to wear corrective lenses to adjust for that? Yeah, it doesn't really help. Wow. Well, good. May. That's gonna be your next procedure. Wow. Good luck. What does the surgery involve? Do they go in there and they adjust the extraocular muscles? Wow. Interesting. So what do? Do they like shorten the length of the muscle? Like, what? Yeah. Huh. Interesting. Wow. Well, good luck with your procedure. Cool. So these are all the different types of amblyopia. As I said, I'm not going to test you on the sub-variations and subtypes. Just be familiar with strabismus. Strabismus, the most common cause of amblyopia. Here's another thing I'm not going to test you on, but is super cool. So anisocoria versus heterochromia. So anisocoria is where you have a difficulty in uh, uh, constricting the pupil size. And so you're going to have differences in pupil size. It might look like differences in color of the eyes, but in reality it's not. It has to do with the differences in pupil size. One of the most famous people that had that was David Bowie. And I included a little story that from this article on Radiox that talked about how this happened to him. It happened to him when he was a very young kid. He got in a fight over a girl, and this guy apparently whacked him in the head. His nail scratched his eye, and it caused permanent damage to his eye. He was still able to see, but he wasn't able to constrict his pupils. And so anisocoria comes from Greek aniso, unequal, core, pupil, and ia, meaning a deficit. Heterochromia, specifically heterochromia iridum, is going to be a differences in colors in both of the eyes. So some people are born with that. Actually, I was talking to one of my students who, I think it was their brother, has heterochromia. So they have two different colored eyes. So one was like hazel, the other one was like blue or something. You can see this in dogs too, right? So there's some breeds especially that have Australian Shepherds. You'll see a lot of heterochromia. Huskies will have heterochromia. Yeah, so dogs, you'll see this quite frequently. You got a question? I don't know the underlying mechanism of it because it might have to do with cranial nerve number 3, right? But if you have the inability to constrict both of your eyes, there's lots of things that could cause that. Maybe it's medications. Certain meds can cause that, right? So like anticholinergic meds can cause that. What else? Certain stimulants can cause that. So like a person who is on like Adderall, they might have like dilated pupils. If someone's on a lot of cocaine, they might have dilated pupils. People who are really, really drunk can also have dilated pupils. But is there like a medical condition that you're thinking that might be associated with that? Really interesting. Has your like primary care doctor ever noticed that or? Yeah, yeah, I mean, everyone's going to be a little bit different, right? So if it doesn't cause any issues, my only concern for you would be you live in Arizona. There's lots of UV light. You wear sunglasses, good. Yeah, do that because when you go to the eye doctor, they actually give you cocaine when you go to the eye doctor. So cocaine is actually a dilator for the pupils, and so there's like two. Sometimes anesthesiologists will also use cocaine as a local anesthetic, but for dilating your eye when you get an eye exam, they tell you to like put on sunglasses, right? Because if you get exposed to a lot of UV light after you have pupil dilation, that can be really damaging to like the retina. So it could cause potential, it could cause like retinopathy and things like that. But yeah, so wear sunglasses. That's good. Very cool. Otherwise, I have no idea what's going on with you. Like I said, everyone's going to be a little bit different. Um, And I'm not going to test you on anisocoria versus heterochromia. I just put that in there because, first of all, I love David Bowie, and second of all, I think it's kind of cool to see how some people have different colored eyes or different shaped eyes. What's up? Yeah, so they have liquid cocaine drops, and it's a very small concentration. So, like, even if you were to like ingest it and try to like get high off of it, you probably wouldn't. It's like so little, but it's like just enough that they give topical administration, so it causes pupil dilation. Right. So cocaine is actually not a Schedule 1 drug. If I remember correctly, it's Schedule 2 or Schedule 3, which means that it has certain medical applications to it. So, yeah, it's fun. Uh huh. Oh gosh. Was everything? Did they resolve it? That is insane. So they had the wrong size lens during a LASIK surgery procedure. That is horrendous. By the way, how long ago did you have that procedure done? 2 years ago? Okay. Because LASIK surgery generally lasts about 20 years. So you're going to be good for 20 years, but then after that, you're going to have to probably start wearing corrective lenses again. I've heavily considered doing LASIK surgery because it's a pain in the neck having to wear glasses and contacts and stuff, but it only lasts 20 years. So I don't know. The procedure is actually getting really good. I mean, your grandma had a really rare, like crummy experience, but nowadays it's actually very safe, high success rate. They go in there with lasers. They'll do like a little bit of a shaving and reshaping of the lens and whatnot. So yeah, it used to be also very painful before, but now actually apparently it's like not as painful anymore. So the technology has definitely improved a lot on LASIK surgery. But thanks for sharing that. That was very interesting. All right, so if you were to do a eye exam, you're also going to want to do a fundoscopic exam. Right? So you're going to be looking for the retina. You're going to try to visualize the retina. This is your optic disc. That's where your optic nerve is. And then the fovea is going to be where you have the highest degree of acuity, visual acuity. And so we're going to talk about the fovea and we're going to talk about the macula when we get into macular degeneration, because the fovea and the macula, that's going to be your central vision, right? And so that's where you have like the highest concentration of cones. Right? So you're going to get a lot of color perception from your central vision. Peripheral vision is going to be more associated with rods, right? So it's going to be like more like black and white in the periphery, but central vision is going to be more color. And then if you were to do a fluorescein angiography, you'd be able to see all the vessels real nicely. And I included a little link to a video here so you can watch what the angiography looks like. It's very cool.
The JAMA Network.
And so with the fluorescein examination, you'd be able to see if there's any sort of like neovascularization, if there's any extra blood vessels that don't belong there. You can see neovascularization with different types of conditions. Like we're going to talk about macular degeneration, and with certain types of macular degeneration, you can get neovascularization, which affects the ability for you to process vision. So this was demonstrating some neovascularization in this person's eye right over here. That's a huge pocket of a bunch of blood vessels that don't belong there. And so that's going to interfere with the ability for the person to see properly. So let's first talk about diabetic neuropathy. And diabetic neuropathy is going to be among the most common causes of blindness. It depends on what literature you're looking at, because I was actually perusing the internet to see what exactly was the actual main cause of blindness. Cataracts, you'll also see it is really high on the list. So I don't know exact percentages, but cataracts are really high on the list. But diabetic neuropathy is also going to be really high on the list for blindness. This will happen to individuals with diabetes, 80% of them after 10 years of diabetes. And there's going to be a couple different types. There's going to be the non-proliferative type, and there's going to be the proliferative type. With proliferative type, remember we just talked about neovascularization, that's going to be proliferative. So you're going to have neovascularization or blood vessels where they do not belong, and that's going to decrease vision, especially if it's covering up the retinas. And then you can also develop glaucoma from that too. Now with the non-proliferative diabetic neuropathy, you're going to get a couple different things happening. You're going to get blood vessels popping and rupturing, so that's going to cause microaneurysms and hemorrhages. You're going to get fluid accumulation, which decreases vision. And then you're also going to get buildup of like lipids and proteins, and that's going to be forming exudates. You also have these little cotton wool spots. They look like little cotton balls, and that's going to be associated with the retinal nerves that are getting inflamed over time. And then this is one thing to keep in mind. Non-proliferative retinopathy can eventually turn into proliferative retinopathy over time. And so this is a good slide that depicts all those different things. So here's your optic disc, where you're going to have your optic nerve, your blood vessels, those look normal. Then you're going to have a couple microaneurysms. So you got a little aneurysm right here with some like potential for hemorrhaging, which is demonstrated over here. Your little cotton wool spots that looks like little cotton balls, and then your lipid and protein accumulation in the form of exudates. And then this is what you would see on fluorescein angiogram. All right, now let's talk about macular degeneration. Now with macular degeneration, this one really sucks because it's affecting central vision. It's going to be affecting the fovea, right, where you have the highest concentration of cones, and it's really bad because you're going to have central vision loss. So it's going to be older adults that get this. You're going to start developing some weird like distortions of the things you're looking at. So oftentimes a patient would say, "Oh, I'm having a really hard time reading, and I'm having a really hard time seeing like little details and things like that." If their peripheral vision is normal, but they're only losing central vision, that's going to be indicative of macular degeneration. 90% will be dry macular degeneration. 10% is going to be wet. And when we say wet, again, it's going to be referring to neovascularization, so blood vessels forming around the macula. With dry macular degeneration, the big key word here is drusins. And drusins are going to be metabolic waste products that build up beneath the retina. And then that's going to cause eventual scarring of the retina. And then you're going to get if it affects the macula and the fovea, that's going to be macular degeneration. And then with wet macular degeneration, that's going to be pretty rapid. So it's a fast onset. It involves neovascularization. You'll get things like bleeds and hemorrhages, and you're going to get scarring of your photoreceptors, as well as atrophies. Let's watch a video on this.
Is a disease which affects the retina. In this video, we will describe the symptoms of macular degeneration. The retina is the layer at the back of the eye which helps us to see the world around us. Macular degeneration causes changes in central vision. Images which were once clear may appear blurred. Later, dark spots may appear and enlarge. Straight lines may become distorted or curved. Colors may appear less vivid or darker. The eyes work together. When one eye loses vision, it may not be noticed because the other eye is still able to see. Each eye must be tested on its own to identify changes in vision. The symptoms of macular degeneration may be found in other eye conditions. It is very important for an ophthalmologist to perform an examination to ensure that no other conditions are present. Dry macular degeneration affects the health of the retina. The retina is the lining of the eye which responds to light. Here, a cross-section of the retina can be seen. In the dry form of macular degeneration, metabolic end products collect underneath the retina. These deposits are called drusen. Over time, dry macular degeneration can lead to scarring or thinning of the retina above. Dry macular degeneration may cause gradual central vision loss over time. Every patient has a different course, and some patients preserve vision for a very long time. Your ophthalmologist will monitor your eyes. Ask about how stopping smoking or vitamin formulations can help to slow the progression of dry macular degeneration. Wet macular degeneration may develop in patients with the dry form of macular degeneration. In the wet form, blood vessels that are leaky and abnormal begin to grow into the retina. Unlike normal blood vessels in the rest of the body, those seen in wet macular degeneration cause swelling or bleeding into the retina. Wet macular degeneration may cause either sudden or gradual loss of vision as these vessels lose fluid or bleed. Untreated, vision loss can progress. The retina, which lines the back wall of the eye, is responsible for sight. In dry macular degeneration, deposits collect underneath the retina. In wet macular degeneration, abnormal blood vessels begin to spread. A molecule known as a vascular endothelial growth factor, or VEGF, is released in wet macular degeneration. VEGF binds to its receptors much like a key entering a lock. VEGF is a signal which causes leaky blood vessels to form underneath the retina. As these abnormal blood vessels leak and the retina becomes swollen and vision may decline. The main treatment for wet macular degeneration is an injection of medication into the eye. This medication is delivered close to the retina after freezing and cleaning the eye, and most patients experience only minimal discomfort. These medications work by binding to the VEGF that is released, much like a sponge.
As a result, the VEGF cannot bind to its receptor. These injections slow or stop the growth of abnormal vessels. As with any medical procedure, injections of anti-VEGF may help to preserve or slow the risk of vision loss from wet macular degeneration. Injections carry risks each time they are performed. They last only a certain time and repeated injections. Talk to your ophthalmologist about the benefits and risks of anti-VEGF medication.
Right. So one more video that we're going to watch in a second. So here's the image of what it might look like on a fundoscope exam. So all these little white spots over here, those are all of your drusins that are accumulating. And then you might also see bleeds that take place. And then here's your fluorescein angiography. And so you can see it really dramatically over here. You got some massive damage to the fovea and the macula. Watch one more video and then we'll take some quizzes questions.
Coherence tomography, or OCT scan, images of the structures of the eye which previously were unable to see. OCT is non-invasive and does not usually require damage. Patient's point of view, all that is required is to keep the eye still while looking at the fixation. The OCT can image the deep threads of the surface in the early stages of macular degeneration. Earlier the disease is detected, sooner it can be treated. This OCT scan, normal retina, clearly shows. In this image, the jelly, or vitreous, in front of the retina, is pulling away from it, far from the central macula. This is called the macular region. In these next two OCTs, as we move forward further still, passing the retina with it. This is called a macular hole and results in very poor vision. It is possible to treat this with this 3D scan shows a vista of retinal fluid developed following cataracts. Patient of the fluid is shown really on the two. We treated this condition with steroid eye drops to improve the retinal profile. This patient, shown in the next two images, has developed an epiretinal surface. As the membrane contracts, it causes distortion. Cysts of fluid. This requires urgent surgery. In wet macular degeneration, unwanted blood vessels burn into the retina, growing layers. These unwanted blood vessels. This can result in massive vision loss. The watery fluid inside the eye drains away to the point where the front of the eye are called the iris. If the gap between these two structures is too narrow, use glaucoma. If spotted early, simple laser treatment prevents the disease. In glaucoma, the transparent nerve fibers that take the visual signal brain. OCT scan can visualize the thickness of this transparent nerve fiber layer. Glaucoma caught in the early stages usually be treated by taking a suitable eye drop to put the pressure in the eye. We believe that all patients over 60 years of age, those in high risk groups, OCT scan
Right. Another pitch. So, by the way, with the canal drainage in med school, it was my favorite term in med school. That canal is called the canal of Schlemm. And that's where fluid, the aqueous humor, gets drained from the eye. And so if that's what gets blocked, that's where you get glaucoma. Cool. Any questions on what we talked about today? Yes? Astigmatism has to deal with your lens. And generally speaking, your lens is going to be kind of, shaped like an oval. With an astigmatism, your lens tends to be a little bit wider. And so that's what affects, your vision. I have astigmatism too. So, it's just I have a differently shaped lens. So it has nothing to do with strabismus. Do you have astigmatism? Your mom does? Yeah, I have to get like special contact lenses. Yeah. Oh, it's really that bad for her. Oh wow. Yeah, thank God mine's not that bad. I mean, I'm basically blind if I take my glasses off, but for contacts, I know I have to like special contacts that deal with astigmatism. But no, that's to deal with the shape of the lens, not if the extraocular muscles are like not communicating properly with the brain. That's a great question. Any other questions? All right, let's run through a few quizzes questions then, and then we can head out of here. I made 18 questions, but we got 10 minutes left, so I don't think we're going to get through all of them. All right, so sensorineural hearing loss. That's going to account for about 90% of all your hearing loss. The remaining 10% is going to be conductive hearing loss. And I believe I asked another follow-up question. Okay, so what's the most common form of sensorineural hearing loss? Yeah, when you get older, right? So what's that called? Presbycusis. Presbycusis. That's going to be associated with just normal aging. That's going to be the most common form of hearing loss. All right, good. Yeah, exactly. So what does this patient have? What's this condition called? It's a little child tugging at their ear, an infection. What's it called? Otitis media. Good, yeah. So if you were to do an otoscope, look into their ears, you're going to see the bulging of their tympanic membrane. You're going to see fluid accumulation behind the tympanic membrane. Right? You're not going to be able to visualize any of the bones like the malleus or the incus. So good. So you're going to usually have this unilateral. If you have all that fluid accumulation in there, it's not going to be sensorineural. It's going to be a conductive type of hearing loss. Right? So that will be a conductive hearing loss. You have so much fluid accumulation in there that you're not going to be able to get sound transmitted through the infected ear. All right, good. Stapes is going to be the bone affected by autosclerosis. Let me just make sure I don't ask this question. What kind of hearing loss would this be? Did you say conductive? Yes, good. So this would be another form of conductive hearing loss. Right, so the stapes is not going to be able to move or vibrate properly, so it won't be able to conduct the sound, right, to be processed. So this is an older individual. Chief complaint, gradually worse hearing, particularly in noisy environments. Remember, these older individuals, you can take them to a restaurant or something like that, and they're going to have a hard time understanding what's being said, right? So this is an older person with presbycusis. What's up? If she was getting vertigo, then yes, you would consider a differential diagnosis of Meniere's disease, right? So presbycusis would look a little bit different. Right? Presbycusis is just going to be the hearing loss. But if you couple this with vertigo, then yeah, you would think, okay, yeah, this person probably has Meniere's disease. Okay? Good on that? That's a good question. All right, cool. And what's this condition called? Yeah, so this is Meniere's disease, right? So 45-year-old guy, vertigo, hearing loss, tinnitus, right? Those are all the things that you would see with Meniere's disease, and most of you all got that correct, so bravo. The triad of Meniere's disease, vertigo, hearing loss, tinnitus, or that constant ringing in the ear. Those are going to be the three hallmarks of Meniere's disease. So if a person has a sty, that can also be referred to as a hordeolum. Okay. And what kind of duct is that affecting? Yeah, it's sebaceous duct. Good, exactly. And it's going to be a bacterial infection. So you can sort of think of it as like a pimple on your eye. All right, so this was a allergic conjunctivitis, right? So this is a bilateral allergic conjunctivitis. If it was unilateral, you might think that it could have been a viral infection, So viral conjunctivitis looks a lot like allergic conjunctivitis. But if I remember on this vignette, the patient has allergic reactions. If I remember, yes, occurs every spring and every fall. So that's kind of, a key giveaway, especially with spring. You get like hay fever season, spring. All right, that's it. Do the rest of the questions on your own time. And then on Friday, we will cover some other topics that are neurological in nature, so headaches and things like that. So, all right, y'all, have a great day, and I'll see you on Friday. Oh yeah, by the way, if any of you want to come visit tomorrow during my office hours, I have meetings at 11, and I have a meeting at 12:15. So try not to stop by during those times. Take care.